Hello, everyone. Thank you for joining us for today's briefing, Exploring the Market Competition Ecosystem, Lessons Learned and Next Steps. I am OK Enya, Senior Policy Advisor at the Alliance for Health Policy. For those who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the policy community that is dedicated to advancing knowledge and understanding of health policy issues. You can join today's conversation on Twitter using the hashtag AllHealthLive and join our community at All Health Policy as well as on Facebook and LinkedIn. On today's panel, we have a Q&A section at the end of the hour. We want you all to be active participants, so please get your questions ready. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark. You can also use that speech bubble icon to submit questions you have for the panelists at any time. We will then collect these questions and address them during the broadcast. As well as the webinar, you can also chat about any tech issues you may have, and someone will attempt to help you. Now, this briefing is generally supported by Arnold Ventures, and I'd like to introduce Alexandra Spratt, Healthcare Manager, to provide some opening remarks. Alexandra, the floor is yours.
Thank you so much, OK, and thank you to the entire Alliance team for their work putting together this panel. I also want to say thank you to today's speakers. I'm so looking forward to today's discussion about healthcare competition and consolidation, which ultimately impacts healthcare costs for consumers, employers, and taxpayers. For those of you who may not be familiar with Arnold Ventures, we are a philanthropy focused on developing evidence-based solutions to important domestic policy issues, things like criminal justice reform, higher education, and healthcare. We fund research, policy, and technical assistance work to advance these policies at the state and federal level. In the healthcare space, we're particularly focused on the primary driver of high healthcare costs for the privately insured, high hospital and provider prices. Healthcare consolidation, the issue at hand for this discussion, is widely considered as a key driver of these prices, as a robust body of research has found that different types of consolidation can raise these prices without corresponding changes in quality. However, different types of consolidation may have different outcomes and may require different policy approaches for improving competition. Today's discussion will dive into these issues. What are the different types of consolidation? What market forces are driving these forces of consolidation? What are policy opportunities for improving these types of consolidation and improving competition in healthcare markets? This event is particularly timely as healthcare market dynamics are increasingly garnering public and policymaker attention in the Congress, the administration, and at the state level. As the speakers dive into the discussion today, keep in mind that healthcare consolidation is shifting the contours of hospital and physician markets beyond cost issues. While it impacts the prices we pay for care, it also impacts how we access it and how our care is delivered. Thanks again to the Alliance and the speakers today for the forthcoming discussion. I hope you all find this informative for your work. Thank you.
Thank you, Alex. Now I'm excited to introduce Thomas Greeny, our moderator for today's event. Thomas is a business professor of law at UC Hastings College of Law. He has written extensively on topics involving health, law, and policy, antitrust law, and healthcare financing, and is a co-author of the nation's leading health law casebook and hornbook. He has testified several times before the Judiciary Committee on the U.S. House of Representatives and consulted for the FTC, U.S. Department of Justice, and state attorneys general on health law enforcement issues. Mr. Greeny, we're so excited to have you here with us today and to hear some opening remarks from you as well. I'll turn it over to you.
Thank you, OK. I'm going to begin with a little table setting for our panelists before we get to them. Our topic today is one that those of us who've labored in the vineyards of antitrust in healthcare have been talking about for many years, the relationship between market concentration and the cost and quality of our healthcare system. Our first speaker today, Professor Fuse Brown, will go into some detail on this relationship, but the gist of the economic evidence is that almost every sector of the healthcare industry is highly concentrated, especially hospitals, specialty physician practices, and health insurance. Second, a strong consensus of economic and policy studies provides evidence that concentration is associated with high prices in each of the sectors I just mentioned. But at the same time, we see considerable diversity in these sectors, especially in the hospital sectors, as large number of those facilities are losing money, while At the same time, some giant systems have accumulated enormous reserves and have become what some authors call mega providers. Likewise, there's a wide diversity among physician practices, with specialists obtaining far more bargaining leverage and higher incomes. And by the way, let me just plug a book recently published by David Dranoff and Lawton Burns entitled Big Med, Mega Providers and the High Costs of Healthcare in America. It's a nice summary of the history of provider concentration and its effects. So the corollary question for lawyers and policymakers is, wasn't antitrust supposed to protect consumers? And wasn't the original intent of those laws to stop abuses that flow from excess market power? Well, first of all, antitrust enforcement has been something of a roller coaster ride in the courts. In the 1990s, state and federal government prosecutors lost a series of litigated challenges to hospital mergers, and concentration increased significantly. However, the Federal Trade Commission undertook a series of retrospective studies of those consummated mergers, which tended to indicate that, frankly, the courts got it wrong, i.e. the prices increased significantly at the merged hospitals, just as the prosecutors had predicted, and that the courts had approved. So armed with more economically sound methodology for defining markets, the government then went on an extended winning streak in challenging horizontal hospital mergers. But it's notable that the government's cases focused almost exclusively on challenging local horizontal mergers, 3-2 mergers, 4-3 mergers, even 2-1 mergers. So there's still considerable uncertainty and cost in challenging mergers. So nearly every week we see significantly concentrated mergers being proposed, not just horizontal mergers, but vertical affiliations as well. So a number of us have pointed out that there are serious holes in the antitrust safety net. The significant growth in hospital acquisitions of physician practices and most vertical combinations have gone unchallenged by the government. Many fly under the radar screen and escape scrutiny altogether. But again, economic studies show price increases result from hospital acquisitions of physician practices. The government's reluctance may be understandable here because the judiciary, especially recently, has shown an unwillingness to accept challenges based on vertical claims. And there is increasing evidence that vertical combinations involving middlemen, insurers, PBMs, may raise costs. So again, it's an open question whether antitrust law can be an effective tool for dealing with many of the major concentrative combinations that are going forward today. Another gap in merger concerns mergers that enable large systems to extend their market power across markets beyond their local markets. And a number of recent economic studies have shown that some acquisitions by health systems that go outside their local markets also tend to increase prices significantly. Those of you who followed the recent Sutter litigation know a private lawsuit and a suit by the California Attorney General have raised these questions, and we'll talk a little about that going forward. So what does all this suggest for healthcare policy? Well, we'll hear from Katie Guddickson an account of the legislative responses to this problem. Many states are adopting a wide variety of measures designed to curb the market power of dominant providers and to address the market concentration problem. And there have been some efforts at the federal level as well. So finally, what we'll do in our session at the end of this webinar, we'll call on the collective expertise of our big brains on the panel to tackle the critical question. What in this politically polarized era are practical and achievable policy solutions to improving competitive conditions in healthcare? So with that, let me give a brief introduction of our exciting lineup of panelists today, and you'll see their full bios in the webinar materials on the Alliance's website. First, we have Erin Fusé-Brown, who is the Catherine Henson Professor of Law and directs the Health Law Center at Georgia State University. She specializes in health law policy, and her research focuses on health reform, consumer protection in healthcare, and healthcare consolidation. Second, we'll hear from Dr. Brian Miller, who is a fellow at the American Enterprise Institute, where he focuses on Medicare payment policy, FDA regulatory policy, healthcare competition policy, veterans health, and public health. Concurrently, Dr. Miller is also a practicing hospitalist at the Johns Hopkins Hospital and assistant professor of medicine at Johns Hopkins University. Next, we'll hear from Kenneth Kaufman, the managing director and chair at Kaufman Hall. For more than 40 years, Ken has been one of the leading thinkers in the future of healthcare and has helped healthcare organizations of all size with their strategic challenges. And we'll also have my colleague from Hastings, Dr. Katie Guddickson, Executive Director of the Source on Healthcare Price and Competition at UC Hastings College of Law. Shameless plug here, a wonderful source for all sorts of information and data about healthcare concentration and competition. She is a graduate of UCSF and UC Hastings Master of Science in Health Policy, where she studied policy solutions promoting competition in the pharmaceutical industry, and she's been testifying widely before state legislators and think tanks about healthcare reform. And finally, we have Christopher Reeler, a partner at Farella, Braun and Martel. Chris litigates complex civil matters with a focus on antitrust and other business disputes. He's handled antitrust matters in Northern California and across the country. So thank you all for joining us. I think we'll have a terrific series of presentations and a exciting discussion at the end. And you are welcome to send your questions through the chat. So with that, I'm going to turn it over to Erin to start the ball rolling.
Hi, everyone, and thanks for that introduction. And thanks to Bailey and Oki and the entire Alliance for hosting this webinar. I'm just going to give a little bit of terminology definitions and talk a little bit about the role of consolidation in the rising healthcare costs, because in some ways that's sort of the why we're all here. You've probably heard from purchasers and consumers and citizens and employers. Everyone is struggling with rising healthcare costs. And the root cause of the US healthcare cost conundrum is soaring healthcare prices driven by healthcare consolidation. So healthcare costs, like any other costs, are a function of price times utilization. But as the late great health economist Uwe Reinhardt noted nearly 20 plus years ago, the key reason US healthcare spending is so much higher than every other wealthy developed country is that our prices are higher. It's not, and here's the important point, it's not our utilization. We don't actually use more healthcare. And so if we really want to control healthcare costs, we have to focus on policies to control prices. And if we want to control prices, we have to look at healthcare consolidation. So that's why we're here today. Next slide. So healthcare consolidation, we can go to the next slide, the one with the news headlines. Great. So healthcare consolidation has been rampant for the past few decades, and it's really continuing at a fast clip. So sometimes the consolidation is obvious, as Tim pointed out, such as when two or more hospitals in the same city or the same geographic area merge. That's a classic example of a horizontal merger. But increasingly, consolidation is occurring through non-horizontal deals. So for example, you may have seen recent headlines about Amazon or CVS making multi-billion-dollar acquisitions of physician groups, or of health plans like United or Humana forming joint ventures with providers or healthcare data analytics firms. These are also forms of healthcare consolidation. The buyers are not just healthcare companies like health systems or health plans, but increasingly they include private equity firms and publicly traded companies. So private equity firms like Welsh Carson are providing a lot of capital to fuel these acquisitions. We also have Walmart and other types of retailers that are providing, entering the space and again, infusing capital, but in the process contributing to consolidation. All right, so what are we talking about when we use these terms like horizontal and vertical? Let's define some terminology on the next slide. So horizontal mergers are the mergers of direct competitors in the same geographic market. So an obvious example, again, are the hospital-hospital mergers, but we also can imagine there'd be horizontal consolidation of physician practices. So if you see, anything that are direct competitors in the same market, that would be considered a horizontal merger. But we are again seeing the rise of non-horizontal consolidation, including vertical and cross-market mergers. So vertical consolidation involves the combination of two or more different steps in the supply chain. So in healthcare, the classic example of vertical consolidation is a healthcare system buying up a physician group. It also could include the combination of a health insurance plan with a large physician practice such as United and Optum, or a retailer, or with a home health provider and data processing platform like the CVS Signify deal. So there are also cross-market mergers, as Tim mentioned, which involve mergers across geographic or product markets, or both. Examples of this include the expansion of the Catholic health systems across geographic regions, across state lines, or private equity-backed physician staffing firms that buy up many practices across many different states. So historically, antitrust enforcers have really not paid much attention to vertical or cross-market mergers because they believe the anti-competitive effects to be either modest or ambiguous. But the evidence is emerging that all of these forms of consolidation pose risks to competition, costs, and access. Next slide. So here are some trends. This data is actually quite dated, but it is showing the general upward slope. And nearly every major segment of the healthcare market is becoming more concentrated over time. So even as of 2016, 90% of hospital markets, 65% of specialty markets, and 57% of insurer markets, and 39% of primary care markets were highly concentrated. Next slide. And this is even an older slide, but again, details hospital consolidation. And over the last 25, 30 years, there's been more than 1,600 hospital mergers. Nearly half of those occurred in the sort of recent past. So hospital market consolidation is still ongoing. And it has increased so much so that the average market in the 1980s maybe had 5 independent hospitals or hospital systems. And that has now decreased to 2 or 3. Some markets only have 1 dominant hospital. If you think about your own local market, you can imagine that is happening in your market and multiply that across the entire country. Next slide. Physician markets, which traditionally were more competitive than hospital markets, are also becoming consolidated, either through the formation of large physician groups or hospital acquisitions or private equity acquisitions of physician groups. And again, recently, retailers are entering the space as well. Many of these trends are exacerbated by healthcare payment and delivery reforms, such as accountable care organizations, where providers are seeking to become bigger to achieve economies of scale and scope that they need to take on risk-based contracting. They use it to invest in common information technology. But most of these physician mergers, as Tim mentioned, are just too small in dollar amounts to be reported under the Hart-Scott-Rodino notifications, and therefore they don't get any review at all. So as of 2022, nearly 74% of physicians are employed by hospitals, health systems, or a corporate entity. And so the era of the independent physician practice is ending. Next slide. And as I mentioned, the main determinant of healthcare prices is provider market power. It's not quality, it's not the input or labor costs. It is really the market power, the power to drive up prices, that has been formed when you see all of this consolidation in the healthcare market. And the consolidation again continues, and many of these are going unreviewed because they are too small to trigger federal antitrust notification, or there's just too many deals going on for the FTC, the DOJ, and even state attorneys general to really keep an eye out for all of the healthcare consolidation that is happening. So all of this consolidation increases market power, which in turn drives up prices for these dominant health systems or buyers. And yet the the higher priced providers are not better quality. So all of these excess healthcare costs from these dominant health systems and dominant players are buying us neither more or better quality healthcare. So next slide. And this is just a short summary of some of the evidence. The reason to be concerned about all of this healthcare consolidation is that it's extremely well documented in the literature that higher levels of concentration leads to higher prices. We know, of course, that hospital mergers lead to significantly higher prices, double-digit increases, particularly in highly concentrated. And of course, now most hospital markets are highly concentrated. But we also see evidence that physician consolidation, whether horizontal or vertical, also raises prices significantly. And what about all the efficiencies and quality improvements from vertical mergers that hospitals and physicians are touting, and all of these different payers and the integrated delivery system reforms are trying to get us? Well, these two are associated with higher prices for hospitals, for physicians, and higher total spending for patients per patient. So the data are all pointing in the same direction. Vertical integration, cross-market integration, and horizontal integration all raise prices. And the evidence of the impact of all of this consolidation on quality is mixed at best. So the net effect of all of this consolidation of healthcare is significant increases in healthcare costs, but without any improvements or much improvement in terms of quality. So I have a couple more slides that I'm going to save for later, and I'll turn it over to the next speaker, because the next just talk about some of the policies that we might be able to use to address the rising consolidation.
Erin, it's Tim. One quick question. You point out, as we know, there's a real gold rush going on as hospitals are acquiring physician practices. Some of them are doing it defensively, in fact. I wonder if you think that private equity should be regarded as at least to some extent, a safety valve that limits hospital acquisitions, and maybe that private equity at least enables some physicians to maintain a degree of independence. Should we look at it that way?
I would love to look at it that way. Unfortunately, that's not sort of how I see it. I think that the physician practice areas that we see private equity scooping up and targeting are not the ones that health systems typically wanted to buy, or payers for that matter. And so we see, in some ways, it's a different market. It's not like a private equity is competing against health systems. They're really looking at a different set of specialists, whether it's the emergency medicine and anesthesiology, to use out-of-network surprise medical billing in the days of the pre-NSA as a revenue stream, or ophthalmologists and gastroenterologists to get more sort of that wraparound procedural revenue. But we see a lot of this activity happening in a way that doesn't necessarily benefit the physician practice in terms of its ability to stay independent, because instead you substitute the revenue pressures of the private equity company and management, as opposed to the integration of the hospitals. So I wish they were, in some ways providing a safety valve, but I think in some ways it's just another version of the same problem.
Thanks. Very interesting. I've turned it over to Dr. Brian Miller. You're up next.
Thank you. Next slide. First of all, thank you all for organizing. I think this is a really timely topic. It's a fun topic, and it's one that, as Tim mentioned, the antitrust community has historically addressed and has not made its way into the healthcare policy community. So I'm excited to see it venturing into our normal space. And I actually worked at the Federal Trade Commission on hospital mergers, so it's exciting to see this merger of spaces and then also hear the winning streak described. A comment on private equity before I move on, which is that it can be an escape valve if private equity firms are actually improving operations, clinical operations that is, as opposed to just rolling up practices to increase their market power against health plans. So it could be, but not necessarily. But on to consolidation more broadly. As a practicing physician, I experienced the monopsony power of health systems in terms of choice of employment, as do many of my colleagues. And so when I was thinking about hospital consolidation, my first thought, of course, was Standard Oil. Next slide. And I'm going to continue for a moment, making us depressed as we just sort of, again, rehash. And, healthcare delivery has horizontally consolidated. 90% of MSAs are concentrated we've had so many hospital mergers, I cannot keep track. It seems like every day in my email inbox in Becker's, there's another hospital merger that is announced. And then, of course, hospitals have been going and buying everything in sight, sort of like me at a buffet, having fun. So they've been buying physician practices, they've been buying ASCs, home health companies, telehealth. They've been going all over the place, and they sort of turned into an octopus, and there are a variety of stats there that you can see. Next slide. So then the question is like, why do any of us in healthcare policy care about this issue? Like, what is it that gets us out of bed in the morning? And what is it that gets members of Congress and their staff out of bed in the morning on this issue? And the answer is well, healthcare, as we've talked about, super expensive, and it's super expensive for the average American making $55,000, $60,000 a year, that $2,000 deductible and 20% co-insurance, and those $20, $30 copays for physician visits and the $150 copay for an ER visit, like that starts to add up. And then everyone says, well, it's just the health plans, big mean insurance companies. And the answer is, well, the health insurance companies are really just a proxy for high costs. It's not that health plans are perfect, but the health plan is offering you an insurance product in whatever marketplace you are, and it's composed of products and services. And if those products and services are from a monopoly or oligopoly provider, your costs are higher. Historically, the healthcare policy community has added increased insurance subsidies that really just mask the problem rather than addressing the underlying issue of consolidation. And then, of course, as a clinician, also as a patient, my concern, and this should be all of our concern, and it's actually sort of the scary long-term one, is that lack of competition produces sort of an ossified market without much innovation. And we're all going to the same place at different speeds, and we're all going to get sick eventually. If you could advance. And so this is what I was talking about. This is from the Bureau of Labor Statistics, and my economist friends and I constantly sort of debate like how you measure labor productivity in a service market. But as you can see, that red, so the dashed dark blue is output, and the light blue is hours worked. Increasingly hours in front of the computer typing out an electronic health record. And then that sort of orangey color is labor productivity. And you can see that about when I started medical school, which was an increasingly long time ago, that curve has remained relatively flat. And that is something that we all experience as patients or family members of patients. Next slide. And so the evidence about harms for horizontal hospital consolidation is pretty clear. And there's this nice, what's the joke? You can pick your favorite study. Well, here you actually really can't pick your favorite study, because all the studies say essentially the same thing, which is that if you buy your largest competitor, unsurprisingly, prices go up. There aren't quality gains, and there are potential patient experience decrements. And then there's a sort of interesting flavor on that in a labor market perspective, which is the sort of loss of the locus of control for clinicians, leading to burnout, which came up in the National Academy of Medicine study. Next slide. So the question we have is what to do, right? We've talked about a long list of problems, and I'm sort of a pragmatist, and I don't want to list problems without solutions. Next slide. So sort of putting on my doctor hat, first thought is, well, we don't want to make things worse. And the first thing, which we have historically gone to and sort of pulled out of our policy belt, is administrative pricing, rate regulation, price caps, restrictions on price growth. So those promote a static market. They're subject to regulatory capture, the physician fee schedule being one of them, as right now there is ongoing a lot of lobbying by medical specialty societies about it. And as a pragmatist, more importantly, it doesn't really work very well. We use price regulation in the Medicare fee-for-service program And going back to my intro to healthcare management class, probably 15 years ago, if you think about cost of healthcare, it's a function of the price of the service, which in administrative pricing we set the growth rate of, the volume of the service, and then this funny thing called intensity of service. So include those little brackets, but fee-for-service directly regulates price, sometimes addresses volume through utilization review and management, prior auth, et cetera, which fee-for-service Medicare does not. And then intensity of care, which remains unaddressed. We have also tried episodic bundling and set prices for DRGs. Well, as we found, you can also just readmit patients, charge another DRG. And then we said, wait, we're going to do the hospital readmissions reduction program, prevent utilization. Then they just admitted patients as an observation stay, which was not included in the index. The answer is that rate regulation is generally ineffective. Capitation, where you set a budget for a population, is one of the traditional tools that's worked. Another tool is that states, as hospitals have gotten increasingly upset with hospital merger enforcement, have gone to something called a certificate of public advantage, or a COPA, where the state sort of blesses a merger and replaces competition with state regulatory oversight. And the FTC actually just released an excellent paper reviewing this. Next slide. So then the question is what can we do? Well, we want a dynamic market. We want people to compete. So the first thing is, well, give the FTC more staff, right? Give them more staff to do hospital merger enforcement. And of course, importantly, address anti-competitive hospital behavior. So right now, the FTC has authority to address nonprofit hospital mergers. They do not have the authority to address nonprofit hospital anti-competitive conduct, which has to get referred over to the DOJ. Not that the DOJ is unable to do this, but it's more efficient for the same staff who do hospital merger enforcement to address other issues related to hospitals. Another thing we can do is, with so much going on, we can create a state competition index to sort of target enforcement, give a map for the FTC and the DOJ. And then, most importantly, take the government's foot off the accelerator. So what has happened is that we've created all these payment policy arbitrage opportunities. For example, we don't and historically have not had site neutral payment. So you can buy a practice and then bill more through the outpatient physician practice, or the OPPS, and then also charge a facility fee. So I run a practice, I get bought by a hospital, the hospital can bump my rate 60%. That's been addressed, but there are other areas where site neutral payment doesn't exist where we can implement it. And that, of course, has driven hospitals to acquire physician practices. 340B is another example where a statute created with the best of intent to provide low-cost pharmaceuticals to populations that otherwise can't afford them has now expanded into a massive program where entire facilities qualify for low-cost pharmaceuticals. But there's no requirement that those low-cost pharmaceuticals are delivered to the patients that actually need them, hence promoting hospital acquisition of physician practices. And then the question, of course, you get is, Brian, well, great, so you take the foot off the accelerator, but is the hospital / now health system going to dump these practices? And the answer is yes. There have been large waves of hospital outpatient practice acquisition, and the hospitals struggle to manage them, and then they end up selling them 5 to 10 years later. So if we take our foot off the accelerator, one, we'll stop acquisition, or at least remove the incentives for acquisition. And potentially then the hospitals will shed some of these practices later, creating a more dynamic market. And then the last one, which is the one that is always the hardest, is encouraging entry, right? Building hospitals is hard. Being a hospital CEO is not an easy job. You have to oversee operating rooms, intensive care units. You have pharmaceutical product supply chain, medical device supply chain. You have all types of clinician labor, you have unions you have to negotiate with. It's not an easy business, insurance contracts to negotiate. So one thing we can do is that eliminate certificate of need, which at the state level allows market participants and the state to determine whether a facility is needed. Now, last time I checked, having our competitors decide if we can open a business is probably not going to be a winning proposition. Two other things that we can do is we can promote competition from physician-owned and operated enterprise with corporate-owned and operated enterprise by eliminating the ban on physician-owned hospitals from participating in Medicare, and then also having potential Stark law reforms in a managed care environment where utilization review and prior authorization can address, if there's inappropriate or abusive practices in self-referral. So with that, thank you, and over to the next panelist.
Thanks, Brian. One quick question. We had an interesting question from our audience asking, how does consolidation affect staffing? Is it one of the explanatory variables that tells us why some hospitals are short-staffed? I think you showed some labor data on that. So can we define between the two?
So I think that consolidation is well, it's bad for all types of clinical labor. So one, if you're a clinician and you're in a market and you have two health systems you can work for, if one health system has a non-compete that has a 25-mile radius, or even longer, you can potentially have to move out of state, uproot your entire family, redo your medical licenses, go through the credentialing and privileging at the facility, and then with all the health plans all over again. So functionally, you're trapped in your job. I actually know an interventional cardiologist whose non-compete was so strong from his monopolist health system that he would have had to move 3 states away. Now, non-competes, I understand, like if you're developing some rare pharmaceutical product and you're the scientist who developed it, has a clear function. But for clinical labor, it seems to be largely abused by monopolists to keep clinical labor captive and at lower costs and unable to then negotiate your working conditions.
Well, I want to save your encourage dynamism slide for our discussion at the end, since you've laid out a nice template of possible reforms. And we'll go to that at the end. Thank you much. And Ken, you're up next. Let me turn it over to you.
Good morning or afternoon, depending on where you are. I want to thank the Alliance for inviting me to participate in this webinar today. Basically, what you've accomplished is giving somebody the opportunity to make an alternative case for this situation. I think everybody else on the panel is unidirectional in terms of their perspective and approach. And I have a remarkably and radically different perspective on what's going on, and I am very pleased to be able to put that forward. If we could go to the next slide. Next slide, please. So my position on this, working in the real world for 45 years as a consultant, mostly to hospitals throughout the United States and mostly to the not-for-profit sector, is that the regulatory approach that's currently being used, especially towards the not-for-profit healthcare organizations in the United States, is based on a very narrow theory that prices to consumers are negatively impacted by consolidating providers, as we've heard from our first 2 speakers. However, if you're actually operating a hospital within the greater American economy right now, you certainly can see as a CEO or a board member that this is an overly narrow way of viewing the healthcare market. The healthcare market really doesn't function in the way that we've heard the description of the first two speakers, and I imagine the next two as well. And rather, regulation would be much improved relative to the provider community if it was seen through the lens of the macroeconomic environment within which health systems actually operate. And so my point here is the following, is that the macroeconomic forces of the current American economy are damaging the clinical and financial integrity of hospitals significantly. And I'll show you a slide shortly that demonstrates this. And so in order to contend with these macroeconomic forces and the ongoing deterioration of provider capability, then a reasonable level of consolidation is going to be required, and not required from the point of view of the hospital business, but from the point of view of how the American economy actually operates on a day-to-day basis, and the fact that healthcare organizations have to operate in that economy. Next slide, please. So everything in the American economy is getting bigger, and it's unrealistic to expect that hospitals don't need to get bigger also in order to generate the necessary level of capital capacity, to generate the necessary cash flow, and in order to be able to invest in facilities and clinical development, innovation, in order to continue to provide a better and better product to their communities. And so this slide is really demonstrative. Here you can see, looking from 2010 to 2021, an 11-year period, which demonstrates how fast and how accelerated our economic changes in the United States. You can see how Amazon has grown during that period, how big they are, how Apple has grown, how big they are, Google, and United Healthcare. And I want to point out to everybody who's on this call today and enjoying this webinar that United Healthcare is now bigger than Google. And you may say, well, you know, that's a problem from your perspective, but the problem is really magnified if you're actually trying to run a hospital in that kind of insurance environment. You can see where Anthem is, and then you can see Kaiser Permanente, the largest not-for-profit healthcare system in the United States, which has both a healthcare provider network and an insurance network, and then three of the larger not-for-profits, Common Spirit, Providence, and Ascension, and you can see how little they've grown over that period of time. My contention is that when you see this kind of size in the economy, and you see this accelerating size, and then you see the hospital providers constrained on their size, it is making it more and more difficult every day for them to compete for the necessary resources in order to provide the services to their communities that their communities demand. Next slide. So here's where we are. You know, the kids have an expression, IRL, in real life, and this is in real life. This is not some study. This is what is happening on the ground to hospitals right now. And so the combination of the pandemic, the inflationary economy that we're experiencing, and a prohibitive and pejorative regulatory environment have seriously weakened the not-for-profit healthcare network with the following results. More than half of hospitals are projected to have negative operating margins through 2022. And under an optimistic scenario, 53% of hospitals will have negative operating margins. And under a pessimistic scenario, 68% of hospitals would have negative operating margins. This is very significantly deteriorating financial performance as compared to the pre-pandemic period. Expenses are incredible in the hospital space right now. Total expenses are projected to increase nearly $135 billion between 2021 and 2022. Labor expenses are projected to increase by $86 billion, while non-labor expenses are projected to increase by $49 billion. Hospitals are likely to face billions of dollars of losses in 2022 under any kind of scenario. And under an optimistic scenario, operating margins will be down 37% compared with 2021. And under a pessimistic scenario, operating margins would be down 133%. But the most important part of this is that we're beginning to see, and I want to make this point to everybody on the call because it's so important. We're beginning to see, because of these numbers and these factors, a deterioration in access to services across the United States. We're beginning to see waiting times for important procedures like colonoscopy and mammograms that are absolutely unacceptable, especially if you have any thought that you might be sick. And this is happening because of a deteriorating financial and resource situation, a harsh staffing environment, and all of that has resulted in the fact that we don't have the same type of clinical access right now that we had before the COVID pandemic occurred, and before these other factors took place. Next slide, please. So how does this actually affect communities? How does this affect communities? So I want to show you and finish with a case study here, which I think is important. And this is what I call the 2-hospital town case study. So basically what everybody on the call needs to understand is if you're in a 2-hospital town right now, you can't merge. It can't happen. You haven't seen a 2-hospital merger in years and years. But the problem is that there are many towns in the United States that are 2-hospital towns. And because of the macroeconomic environment and the factors that I've shown you in 3 previous slides, and the regulation that will not allow these 2-hospital towns to consolidate, you have a harmful set of factors that are developing for care in these communities. And so what is developed historically, these 2-hospital towns had very significant demographic reasons for being 2-hospital towns. And in many cases, there was one hospital that was in the community that developed for ethnic and religious reasons, and another hospital that developed in another way for other ethnic and religious reasons. But those reasons in developing the 2-hospital town sometimes go back 80, 90, 100, 125 years to an economic time that does not relate to where we are right now from a macroeconomic structure. So the best way to develop, to provide a higher level of access and a higher level of quality in these many 2-hospital communities would be to merge to one hospital, because that is the economic set of relationships that we have right now. And health system executives would view the merger option as a far more positive approach for a community than the alternative. And the alternative right now allows one organization to decline financially and clinically over a period of years. So you have one relatively good hospital in town, and you have one relatively hospital that is having a harder and harder time providing significant clinical problems. So over the past 20 years, the regulatory apparatus has made it close to impossible for hospitals to merge in these 2-hospital towns. The most recent decision was the prevention of a 2-hospital merger in New Brunswick and New Jersey. So such a regulatory approach is actually, in my opinion, raising local health care costs and forcing the maintenance of service lines and access in that community whose quality is suspect. And with that, I'd like to conclude, and I look forward to the discussion periods. Thank you very much to Mr. Greeny for moderating the conversation.
Thank you, Ken. You raise a number of really interesting points. Let me ask you about the negative operating margins of many hospitals. How much of that is attributable to the ungenerous reimbursement policies under Medicaid and the lack of expansion in the non-expansion states? Are those the hospitals that are really taking the hit? And is your brief sort of in favor of more generous government reimbursement?
Well, I think eventually I have to get to that, right? So So the reasons for the reasons for the financial difficulties that we've entered into 2022, I think, are related to three factors, and we're not. I think much of it comes from the pandemic, but we can't unpack that yet. We just don't know enough about unpacking it. So we have Medicaid reimbursement in most states, which is ungenerous in your wording. We have Medicare reimbursement, which is insufficient for most hospitals. But we also have the commercial players, the Blue Crosses of the world and the Uniteds of the world, who are beating down on hospitals in an unprecedented way right now. I did a major talk for large system CEOs a number of months ago, and I wasn't 15 minutes into the talk, and the only thing they wanted to talk about was the difficulties they were having with the large third-party commercial payers, not only in terms of the rates that they were getting, but the fact that they weren't getting paid in a prompt and timely and fair way. So you take that, and then you combine it with this expense problem that we're having right now through the inflation, and it's generated significant losses for many organizations. I want to point out to your audience, however, that they're probably thinking that the losses are in, the hospitals that were already struggling. That is not true. The Cleveland Clinic reported $1 billion loss for the last quarter. Mass General recorded a $900 million loss. Ascension recorded a $2 billion loss, and Ascension hasn't lost a dollar in 40 years. And the same is true. You can just go down the line. So would Medicaid expansion help? Yes, but I don't think it relates to your point in the way you thought that it did. Thank you.
Well, thank you. Let's move along. We're falling a little behind, but let me move it on to Katie Guddickson, who is going to talk about efforts at the state level and federal level as well to try to come up with solutions.
Thanks, Tim. You can put on that next slide. So thanks to the Alliance for inviting me here today and for putting on this interesting seminar. I'm going to spend the next few minutes talking about what state policymakers can do about consolidated healthcare providers. Next slide. And so in my research, we typically like to think about these sort of state actions in two buckets. The first is what states can do pre-merger to prevent any competitive consolidation and to be sensitive to consolidation that should happen. And in the second bucket is what states could do after consolidation has happened to help mitigate the harms, the pricing harms of consolidated markets. And I'm going to talk very briefly about both. So first, I'm going to talk about what states can do to prevent future harmful consolidation. And that includes increased notice of proposed transactions and an administrative review process. Next slide. Because antitrust enforcers have been loath to unscramble the egg or break apart health systems once they have merged, it's particularly important for states to become aware of and review transactions before they happen. So as Aaron mentioned, transactions that are above the Hart-Scott-Rodino threshold, which this year was over $100 million, those transactions must give federal regulators 30 days notice before they close. And while this is important for large mergers, it may certainly miss acquisitions of small hospitals and almost certainly miss acquisitions of small physician groups. At the source, we've looked at state merger review laws across the country to examine state laws that supplement these federal requirements. And as you can see, many states require nonprofit hospitals to file notice with the AG's office or a state certificate of need program, sometimes the Department of Health. And those reviews are typically to make sure that the transaction is within the charitable mission of the hospital. Often this is not really an examination of antitrust concerns, but in some states like California and also in Rhode Island, the state allows the AG to oppose the merger if it's not in the public interest. 3 states, Colorado, Hawaii, and Rhode Island, require this notice of all hospitals at least 60 days before closing a merger, giving the state AG time to review the merger. And 4 states, Washington, Oregon, Connecticut, and Massachusetts, require most physician groups to report to the AG or some other state agency prior to an acquisition. Now, while this helps the state monitor consolidation, typically the AG still has to go to court if they really want to oppose the merger. And so the significant time and financial resources needed for a trial means that in many states, the AG is only likely to block the largest and most problematic mergers, which leaves states vulnerable to serial acquisitions or stealth consolidations where one health system or private equity group kind of rolls up a number of physician practices over time. Next slide. So I wanted to talk for just a minute about 3 states that have established a separate state agency to review proposed transactions and to give better oversight of the state on healthcare markets in that state. So Massachusetts established the first one, the Health Policy Commission, back in 2012, and it had been the only state with one of these commissions for a long time. Any provider organization that has more than $25 million in patient revenue has to give the HPC a notice of material change 60 days before the close date. And then the HPC doesn't actually have the authority to directly block mergers. Massachusetts left that authority with the AG, but the HPC conducts a cost and market impact review to see if they determine that the proposed transaction might be detrimental to cost, quality, and access to care. And then the HPC issues a public letter and can collaborate, basically give that report to the AG, who can use that in court, and those reports are often persuasive to a judge. And this collaboration has actually successfully challenged many mergers, and now mergers in Massachusetts often need something other than market power to justify a merger. Much more recently, the state of Oregon passed a law in July of 2021 that gives the Oregon Health Authority the authority to review transactions, and their review process began last March. With a few exceptions, healthcare entities with revenues above a threshold have to report to OHA before closing a transaction. Now, the Oregon Health Authority has actually a 2-stage review process. So in the preliminary review, the Oregon Health Authority has 30 days to decide if they think that there's going to be significant adverse effects in cost, access, quality, or equity of healthcare in Oregon. And if they decide that there are likely detrimental impacts, or likely to be, then OHA has additional time to conduct a comprehensive review. And during this review, they can actually convene a community review board to discuss things like access, whether the hospital or facility is needed in the community, what kind of services there could be that are important to preserve. And at both the preliminary and comprehensive stages, OHA can impose conditions on the merger. They also have the authority to outright block a merger, but they can impose conditions like continued access to care, keeping maternity wards open, et cetera. This program is very new, so OHA has only reviewed a handful of transactions, and so far all have been approved at the preliminary review phase. Now, earlier this year, California established the Office of Healthcare Affordability with approval of the 2022 budget. Like Oregon, OCA appears to be building on Massachusetts' successes, but the details really aren't known yet. The regulations haven't been established. So I'm not going to talk in detail about OCA, but they begin reviewing transactions in April of 2024. In addition to sort of these market oversight reviewing proposed transactions, all 3 of these agencies have the goal of improved transparency and affordability of healthcare in the state, which leads me to the second bucket of state actions. So next slide, please. These are options that states have to restrict the use or abuse of extant market power. So in many markets, you can pick your analogy. The train has left the station, the horse has left the stable, et cetera. But it's clear that just preventing future mergers isn't going to do much to improve competition or constrain prices. So state legislatures have done a few things. First, they have passed laws restricting the way that health systems are allowed to contract with insurers and use market power in one market to increase prices in another market. And some have passed laws more directly restricting the pricing power of dominant providers or just more directly affecting prices. So next slide, please. I think Chris is going to talk more about the lawsuit against Sutter Health and sort of that situation. But briefly, the injunctive relief in that lawsuit in California and also the lawsuit against Atrium Health in North Carolina contain provisions that prohibited health systems from using particular contracting practices. And these include bans on all or nothing contracting. That's where a health system demands an insurer take all of their facilities or none of them. So if this health system has a dominant market position in one market, they can essentially tie that market power to other communities that should be competitive. And then secondly, anti-tiering or anti-steering clauses. If a health system uses these, they essentially tie the hands of insurers who want to steer enrollees to more cost-effective, higher value care. So in the last legislative session, 7 states considered, and Nevada became the first state to pass a law prohibiting all or nothing contracting. And similarly, 8 states considered bills prohibiting anti-steering provisions, and Nevada joined Massachusetts to become the 2nd state to ban these clauses. The savings from these laws could be substantial. One economist used data from Massachusetts to estimate that in the most favorable market conditions, bans on anti-steering and anti-tiering laws could save up to 12% of healthcare costs. And that's both through steering patients to higher value providers, sort of lower cost hospitals, and in reductions in negotiated prices as hospitals have to compete more effectively for inclusion in networks. Next slide, please. And finally, I want to talk about where I think many states are headed in controlling healthcare costs, and that's in more directly restricting prices or price increases. And I think states have a spectrum of options that they can consider if they want to think about more directly affecting prices. At one end of the spectrum are cost growth benchmarks, and this is where a state establishes some target for the rate at which total healthcare expenditures should increase in the state in a year. And typically it's pegged to inflation or median income, something like that. Cost growth benchmarks are mostly a transparency tool, and they kind of set expectations for insurers and employers in their negotiations about how fast healthcare costs should increase. Currently 9 states either have or are actively implementing a cost growth benchmark. This includes the 3 state agencies, the 3 states that have agencies that I talked about earlier, Massachusetts, Oregon, and California. And all of those agencies also oversee this cost growth benchmark program. Determining compliance with the cost growth benchmark for an individual provider can be a bit of a problem, and all 3 of these states do establish financial penalties for entities that don't comply with the cost growth benchmark. But after a decade without any penalties, Massachusetts just issued its first performance improvement plan for Mass General. And the maximum penalty it can apply is $500,000, which is less than 0.2% of the amount by which the state claims that Mass General exceeded the benchmark. So whether this is really an effective way for controlling costs or more a way to bring expectations and transparencies to states is an open question. At the other end of this spectrum are population-based models. These are essentially the capitated models that Brian mentioned. And that can be where a state establishes a budget for the total cost of care for some population, and then participating providers are responsible for providing all that care to the population. Vermont has an all-payer ACO model that comes close to this population-based model, and their all-payer ACO includes Medicare, Medicaid, and the state's largest commercial insurer, Vermont Blue Cross. But Vermont's model is largely voluntary, and participation of hospitals, especially rural hospitals, critical access hospitals, and employers with self-funded insurance has been lower than hoped. In between are some things that I'd be happy to talk about in the questions, but I don't have time to talk about them all. But for example, there are affordability standards where the Department of Insurance can set maximum rates at which premiums can increase in a year and limit the rate at which provider prices can increase. These can be pretty tuned to be sensitive to conditions in the state. In addition, I just wanted to mention flexible global budgets because these can provide this is the payment model where the state decides what the budget for the hospital should be for the year. Often this is set through negotiations and historical rates, and it can be partially set and then partially fixed based on volume. And this can help support hospitals through tough financial times like the pandemic, where Maryland's global budgets actually help the financial status of hospitals in their states. So I'm happy to talk about any of these more in the questions, but what I really want to emphasize is that states should make sure that they have, state policymakers should recognize that they have lots of options to consider when trying to mitigate harms of consolidation, both before it happens and then in consolidated markets. And states are uniquely positioned to think about local market conditions and specific providers in their states and tune these policies to match those. Regardless of the policies, states should make sure that they have notice of proposed transactions so they have time to review them to determine if they're in the public interest or likely to cause harms. States can set up agencies to review the impact of proposed transactions on anything that the state thinks is valuable, but specifically cost, access, quality, and equity. And then they can place conditions on specific mergers in ways that the feds are unlikely to do in local markets. And finally, states should consider ways of addressing market power, either through bans on anti-competitive contracting practices or on more directly restricting prices. And I will turn it over to our next panelist. Thank you.
Thank you, Katie. One quick question here. It looked to me from the maps and what we've looked at on the source, it seems like this is somewhat of a red state, blue state phenomenon. In other words, the states that are active in initiating reforms directed at price and maybe moving towards rate setting or global budgets are blue states. Is that right? And if so, which of these reforms are viable outside of the blue world?
Yeah, I think the state agencies and sort of, once we talk about price setting, those are clearly a blue state phenomenon. But I think that many of the other, especially contracting practices, that's a really pro-business approach. And I think many of the red states are moving in that direction. And some states like Nevada aren't necessarily the first ones that come to mind when I think of dark blue states. So I think as state policymakers are recognizing how healthcare costs are crowding out other state priorities and affecting employers in their states, I think we'll see more motion, especially at the left-hand side of the graph here, sort of overall caps or some kind of restrictions that allow businesses or industry to negotiate under those caps to control costs.
Well, very interesting. Well, we're going to run through your smorgasbord of options with the full panel in a few minutes. But first, I want to turn it over to our last panelist. I was going to say our Aaron Judge batting cleanup, but I'm a Red Sox fan, so I'll call you David Ortiz. But Chris, take it away.
Hi there, Tim. Can you hear me?
Yep.
Great. Thank you. Thank you, Tim, for passing the baton to me. Thank you to the Alliance for putting together this extraordinary panel of real experts. My practice is representing state attorney generals who are concerned about healthcare antitrust issues. And Tim had remarked at the outset that we are in a politically polarized environment. I can tell you that concerns about healthcare are not a blue state or a red state phenomenon, that my clients in red and blue states are very concerned about this. And I don't think there's anyone who believes that spending 19% of our nation's economic output on healthcare is acceptable. I want to pick up a little bit on some points that Katie had made and talking a little bit about what the state's perspective is here. Once you have a concentrated market, be that a provider market or an insurer market, you really have two options. One is you can try to regulate that market, or second, you can try to enforce antitrust laws if you see conduct that you believe is anti-competitive. Both of those approaches are imperfect. Regulation, as I think Brian explained quite well, is often imperfect. It's very difficult to replicate the effects of competition. And enforcement is very expensive and very slow, as the Sutter Health case, which I litigated, demonstrates. In the federal Sutter Health case went to trial earlier this year. That case was filed in 2013. So if it takes you 9 years to get to trial, that tells you something about what is involved in enforcing antitrust laws in the healthcare context, albeit that was a private class action. So it's important for states to make sure that their markets do not become excessively concentrated in the first instance. And I do believe that effective merger review is a big part of that. The problem with merger review is that it is expensive and it is specialized. And so while the Federal Trade Commission has significant resources and expertise, including in-house economists, state attorney generals do not have that. And I want to talk a little bit about what we saw earlier this year in Rhode Island, where the Rhode Island AG was asked to review the merger between the two largest health systems in Rhode Island. Ken had referenced 2 hospital towns. Rhode Island was essentially a 2-hospital state. And the 2 largest health systems, Lifespan and Care New England, had proposed to merge. They would have collectively accounted for over 80% of inpatient discharges in the state of Rhode Island. And when Rhode Island had a unique tool called the Hospital Conversion Act, and just a couple of years ago, they had added to that statute an additional criteria for reviewing hospital mergers, and that criteria was compliance with the Rhode Island Antitrust Act. And they were able to use that process to conduct what I think is a uniquely meaningful review. Full disclosure, I represented the Rhode Island Attorney General in that review. But there were a number of issues that came up in that review that I think are relevant to the discussion that we're having today. The first is Rhode Island does have a regulatory body called the Office of Health Insurance Commissioner, which sets what are known as hospital rate caps in Rhode Island, and also certain quality metrics. And OHIC, as it's known in Rhode Island, has been lauded for its work. It's been, I think, a very favorable article in Health Affairs, described how effective it was. And the merging parties relied upon OHIC to say, look, you shouldn't be concerned about prices because we have this very effective regulator who's going to keep prices down. Ultimately, the Rhode Island Attorney General concluded that that was not persuasive, that no regulatory regime is immutable. All regulatory regimes are subject to regulatory capture and political pressure, especially when you're dealing with very politically powerful large employers in the state. And it's very difficult, as I said at the outset, it's very difficult to replicate the effects of competition. There are many non-price dimensions to competition, such as innovation and access. It simply cannot be regulated through a regulatory body. So ultimately, the Attorney General found that the OHIC was not a sufficient basis to allow the merger to go forward. There were a couple other issues in that merger that I think are relevant to the discussion we've had today. One is this notion of efficiencies. Under antitrust law, merging parties can show that there are efficiencies that will offset any anti-competitive effects from a merger. Those efficiencies have to be quantified, and they have to be certain, and they have to be persuasive. I would defer to the other panelists and folks who specialize in merger review, but it is very difficult to imagine 2 merging parties who could satisfy the efficiency test to demonstrate that there are quantifiable efficiencies that are going to result from merging 2 very large organizations together. Certainly, that was not the case in Lifespan Care New England. There's also another applicable antitrust doctrine, I think it's relevant to something that Ken had said, which is called the failing firm defense. That if there is a hospital that is in dire economic circumstances and would not be able to continue in existence but for the merger, then the failing firm defense can be invoked to offset any concerns about the anti-competitive effects. So there are antitrust doctrines that allow for mergers that would actually benefit consumers. And so I just wanted to be clear on that point. I want to talk a little bit about Sutter, but I can save that for Q&A, Tim. I think one interesting takeaway from the Sutter litigation, and there were 2, there was a state court action and a federal action, are that the Sutter case really started many years ago in the early 2000s, where the California Attorney General attempted to enjoin a merger, an acquisition of Sutter Alta Bates in Berkeley, of Summit Hospital in Oakland, and failed, in part because the prevailing geographic market methodology at that time resulted in a very significantly larger geographic market than the FTC found was appropriate later. So I think the Sutter case illustrates kind of what can happen if you are not in a position to be sufficiently diligent about mergers, and if entities are allowed to obtain significant market power, what can happen down the road and the types of problems that you can deal with down the road. I won't get into the Sutter Health case in kind of excessive detail. I will note that there were two cases and there were two different results. In the state case, which I litigated, the case settled right before the jury trial, and for $575 million and very comprehensive injunctive relief over the next 10 years, including a special monitor who is overseeing Sutter's compliance with the injunctive relief, which would prohibit some of the contracting practices that were issued in the case, including, as Katie discussed, all or nothing contracting, anti-tiering, and also price secrecy. In the federal case, however, which went to trial earlier this year, that resulted in a defense verdict for Sutter. And there were some differences in those cases. The federal case did not have a government enforcer, which I think illustrates in part kind of how effective a attorney general private partnership can be in litigating a class. It was a different class. It involved insured entities rather than self-insured entities. It was in federal court, not in state court. There's some significant differences there. And there are some different legal theories and some difficult rulings in the federal case. But I think the real takeaway to me of the Sutter case to today's discussion is that it really began much earlier. And it began at a time when a system in Northern California, which is the dominant system, first began amassing that market power. And it was interesting to see that, decades later, we're kind of dealing with the effects of that. So with that, I know we're short in time. I will stop, and I'm happy to discuss at further length any of these topics.
Thank you, Chris. I think we're going to open it up to all panelists now. I don't see everybody's face out there yet, but let me just invite anyone to sort of jump in. We've heard quite a smorgasbord of policy options, both at the federal and state level, and we've heard Ken's defense of consolidation and the need to protect the two-hospital town from, in some ways. Let me just ask anyone who wants to pitch in on with a vote for either a range of policy options or some way to deal with this, or whether we should just keep on keeping on. Anyone want to take on the triage of policy options out there?
I'd be happy to, but I have a question first, if that's all right.
Sure.
Ken, you mentioned and Chris, you both talked about the failing firm defense, which is a well-regarded theory in antitrust. It's not very common in the hospital industry, but I guess my question, Ken, you mentioned a variety of facilities that are under a lot of financial stress now. I looked at one of them, the Cleveland Clinic you mentioned has a large loss. But looking at their balance sheet, it looks like they have $12 billion in long-term investments. During the pandemic, they got a $650 million credit line. They had $447 million in investment income. They turned a net profit during the pandemic with $352 million in CARE Act funding. They bought a hospital, and then they opened a private hospital in London targeting wealthy expats from the mainland and other countries. So I guess my question is, sounds like Cleveland Clinic is having a bad year, but do you consider them a financially distressed firm when they have $12 billion in long-term assets to cushion many years of potential losses? Or
no, the Cleveland Clinic is a very well operated financial organization. It has to be, because it's a world-renowned organization, and its ambitions and approaches to care in terms of what it wants to do is not nationwide, it's worldwide. And it should be worldwide because people from all over the world come to be taken care of the Cleveland Clinic. It is regarded as one of the 5 best hospitals, not in the United States, but in the world. So they've accumulated the resources that are necessary for them to operate at that level of ambition and capability. The point is that for that organization to be in a operating loss position is stunning. and it reflects the overall circumstances that we have right now. It doesn't mean that they're going to fail. It doesn't mean that they aren't going to recover, but it's an indication of where we are across the country right now and how fragile our hospital systems are. Now, you use that as an example, but you could go to other examples that have much worse balance sheets and whose operating losses are putting those organizations and their communities at significant risk. And we could find those examples of those easily as well.
Thank you.
Well, let me ask about some of the specifics that are out there. We've heard some states and some of the states that are proposing regulatory entities to at least set price cap, set price goals in the first instance, but many of their supporters see that as a first step on the road to rate caps or rate regulations in some form or another. That obviously is going to be a blue state, red state divide as well. But let's hear a little about the pluses and minuses of rate capping, because at least some economists would say if you have a durable monopoly, there should be rate regulation. On the other hand, our history on that score is not an encouraging one. Any thoughts on the drift towards rate caps?
Tim, this is Erin. I know my camera isn't working, so I will jump in with at least a quick response to that question. I think a lot of economists would say, yes, the first choice would be perfect competition, which we already don't have. And so what we would have instead is sort of what is our second best option, given that we have a marketplace that is not competitive, and that really what we see is sort of maybe healthcare, particularly hospital care, is more like something that tends toward a natural monopoly or a natural duopoly, where it's more like a public utility. In that case, well, what is then the way to constrain monopolistic pricing? And a lot of economists have said, yeah, that in that scenario, rate capping might be a preferable solution to rate setting. So what's the difference? So rate setting is where the government, whether it's the state government or the federal government, rolls up its sleeves and actually sets the price for every item and service that's offered. And you can think of Medicare, fee for service being an example of that. And we had states that did that back in the 80s and maybe early 90s. And it's really, really difficult to do. It's extremely, it's hard for a government to do that really well, particularly at the state level. So what we have instead now is this idea of a rate cap, which is the idea that really, whether it's in network or out of network or some combination, prices shouldn't exceed a certain benchmark, whether it is a multiple of the Medicare price or whether it is something pegged to the average negotiated rate in that market. And so the idea is that you really are just targeting, what we're really worried about are not the struggling hospitals or the places that have competition. What we're worried about are the sort of very large dominant health systems that are using their monopoly power to extract higher and higher prices, and that have no constraints, basically, because every health plan needs them in their network. And so the idea here would just be to cap those top prices and say everyone has to still negotiate. There's still competition below the cap, but we're just going to put some downward pressure on the very tippity top because it's that monopoly dynamic. And that there have been several models, again, that we don't have an example of this being implemented, but we do have some models where that is actually quite effective at generating some savings. Even if you just cap out of network prices, it again might force everyone back to the negotiating table to be able to negotiate better in-network rates. And again, we're really only targeting those top of the market prices and allowing competition to still exist beneath the cap. So that's the plus on the side of the ledger. The minus would be there's always a fear that it's going to become what's called a magnetic ceiling, and that once a top price is named, that even the smaller, more value-based providers might gravitate to that top price if they can. But then the question is, if they could already get that price in the market, why aren't they getting it now? I think there is that question.
Ken, I'm guessing you want to take issue with Aaron's kinder, gentler price regulation?
Who are you asking?
Ken, you.
That I want to take issue with, well, I've never seen price regulation work, and I've been in the industry for a really, really long time. It doesn't work from, as indicated, it requires a regulatory body to operate at the highest level of its certification, and that generally just hasn't, it isn't what's happened, and it makes it very difficult for hospitals to operate in an unfettered way and to respond to the needs and changes in their community. And you know, and I would say something which I would imagine that everybody on this webinar would disagree with. I don't think the consumers like it. I don't think most of the, when it comes right down to it, most of the consumers don't. That's not how they see what America is. They don't. And this is, and you know, when you talk about the important industries in America, there's no more important industry in America than the healthcare industry. And people talk about, they complain about higher prices, but when they want what they want, and when they're sick, they want to be there. So somebody in Maryland who lives, you know, 90 miles away from Hopkins, but they get a Hopkins level disease, they want to go to Hopkins. And they don't want anybody in government telling them where they can go and who they can see and how they can be cared for at that time. And that's how the American public feels about this, without a doubt.
So something revolutionary, I actually agree with Ken. The history of rate regulation, I know, and it's shocking considering my last question. We just blew our audience's minds. But the history of rate regulation at the global budget state level, it didn't work well. You know, it didn't work in the 80s, didn't work in the 90s, and most of the states shed that. I think Chris made a really important comment earlier where he said that competition is great and regulation doesn't capture competition. Like, it doesn't replace competition, and there are non-price aspects of competition. And so I think if we skip and go straight to rate regulation, we ignore the whole issue, which is that we need to figure out how to restore competition in a dynamic market.
Tim, can I pose a question on that? Actually, that picks up on something that Brian had said. Brian, you had flagged kind of removing, because I can't make peace with the lack of competition for the reason you just articulated. You had flagged the possibility of removing barriers to entry, including certificate of need laws. I wonder if anyone on the panel has any thoughts about other barriers to entry and how they might be removed, so we could, even in markets that are concentrated and we can't unscramble the egg, we could induce new entrants into the market.
I've written about the physician-controlled hospital issue, which is a tricky one because there's the risk of cherry picking and all those things that could occur. But there is some argument that at least that could provide a little bit of a relief valve in the market. And going along with what Brian just said, as one who is notoriously skeptical of regarding certificates of public advantage, that model of regulation is not one I would endorse either.
Well, the COPAs have developed in the red states because of a strong hostility in certain circumstances to Washington. You know, the COPA in Albany, Georgia, and then the COPA in Tennessee, Virginia. I mean, those states just didn't like the answer to that, and so that's where the COPAs came from. And I know that the FTC is very disagreeable about the COPAs, but if the FTC doesn't take a more, you know, reasonable approach to individual situations, then they're gonna get COPA'd all over the place. That's my opinion. You know, I think it's really hard to justify certificate of need at this point. It really is, and I agree with Brian's perspective on it. You know, if you're a well-run healthcare organization and you have a lot of confidence in what you do and you think you've got good doctors and great relationships with your patients, and what do you have to fear about certificate of need? The one thing I didn't agree with, Brian, was the physician-owned hospitals, which I think is, you know, all you have to do is read a little at Tua Gawande and you'll know what the problem with that is. So.
Well, as the moderator and bartender of this organization, I'm going to have to declare closing time. I want to thank everybody, and if we can, I think it's time for me to turn it over to the controllers here for some final thank yous. But thank you to all of you for your interesting and provocative analyses, and we'll see where we go from here. Okay.
Thank you so
Thank
much.
you. Yeah,
Thank you.
thanks, Tom. Thank you.
At this time, please take the time to complete the brief evaluation survey that you'll receive immediately after the broadcast ends, as well as via email later today. Please join us next Wednesday, October 26th, for our briefing, Rebuilding Trust in Public Health Messaging. A recording of this webinar and additional materials will be available on the Alliance website. This officially concludes our time today, exploring the market competition ecosystem, lessons learned, and next steps. Again, thank you to Aaron, Brian, Kenneth, Katie, Chris, and Tom. Thank you.
Thank you.
Thank you.
Thank you.
Yeah.
Thank you.